I have nothing to disclosure. So, cervical cancer is a great problem in my country. We have around more than 5,000 cases every year, and 2,000 deaths of women every year too. The stage presentation, they are locally advanced. Between 56 to the 77% of them are locally advanced patients. Okay, at the mid-80s, nothing was changed in terms of survival between the two treatments at that moment, the radiotherapy or surgery. But the introduction of chemotherapy to the primary treatment of the cervical cancer was an iconic moment. These are the kind of cervical cancers we receive every day in our hospital and in the public health area. Very bulky tumors in young patients, 1B2 or the old 1B2, 2B and 3B cases with bulky tumors. These are all the treatments we know, everyone, and we are using today. And what do the chemotherapy, in summary? Reduce the tumor volume, increase in operability, allows us to perform better radiotherapy, and the treatment of micrometastases. Disadvantages, okay, we can develop resistant clones or delays, in some cases, the primary treatment. There were a few iconic, I believe, papers published about neoadjuvant chemo. This is the first one, randomized trial for the 1B, and first of all, it introduced the concept of maximum tolerable doses of cisplatin or the chemo scheme in short-term intercourse of the chemo. The same paper or the same strategy was carried on to the 2B and the 3B. And in summary of our experience, what we could learn about the papers, first of all, for the old 1B1, it increased a great number of pathological responses and a much better locoregional control of the disease, decreasing the disease-free interval. So it made us think about, is it possible to perform less radical treatment with these findings? Other thing was that increased operability in all the cases of neoadjuvant chemo, especially in 1B2, we could operate all the 100% of them. The same occurred in the 2B, but what we learned specifically from the 2B, that non-responder patient or chemo-resistant patient have a poor prognosis, and the only chance they have is surgery, because they will be also radio-resistant patients. And of course, decrease the pathological high-risk factors. Increase overall survival in all the stages, 1B, 2B, and 3B. But we were not alone at those days. At 2002, the Italian randomized trial, the national Italian randomized trial, showing us that chemo followed by surgery was better than radiotherapy alone. In the Southeast, people from Taiwan, Dr. Lai, or Dr. Kim from Korea, arrived to a similar conclusion that our papers, the Italian papers, and reconfirmed Dr. Kim that the chemoresistant problem in the 2B patient, where surgery transformed into the best option at the moment in chemoresistant, radioresistant patients. And what happened after that? The meta-analysis, the 2003 meta-analysis. It was made with 21 randomized trials and with the individual data of the patients. Compare neoadjuvant followed radiotherapy or followed by surgery, and there were no differences between groups, to the toxicity, what happened with neoadjuvant followed by surgery versus radiotherapy. Confirm again that neoadjuvant chemo followed by surgery were better than the radiotherapy alone. In summary, this meta-analysis shows us that survival was increased. We could obtain a much better local regional control, and reconfirm again that we must use a maximum tolerable dose in chemo in short-term intercourses of chemotherapy. But what happened from 2002 or 2003 up to in this 10 years? Many papers were published, and in 2012, the same group of the meta-analysis arrived to similar conclusion 10 years after. And for the 1B1, the meta-analysis of the 1B1, published by the Professor Kim and the last appearance of Juan Sardi, arrived to similar conclusions for the 1B1, reducing or obtaining a better local regional control, obtaining much more pathological responses at the surgical specimens, and the idea of performing less radical treatment arises again. Okay, for us, again, the Back to the Future effect, we call it, because the dose-dense schemes of the new wave of the high dose or dose-dense schemes arrived to the neoadjuvant chemo too, showing that it's better to give to the patients the maximum tolerable doses in short terms of chemotherapy. And what happened after? What about the comparison about neoadjuvant chemo followed by surgery versus chemoradiation? This is a very interesting patient. Unfortunately, Javier Vidal-Reta passed away last year, and he couldn't publish the whole paper, but he presented it at the IGCS regional at Chile in 2015, and he compared both treatments, but the most important, there were surgically staged patients. So I believe this is one of the keys to open the door to select much better the patient for the treatment we are going to perform. So in his paper, neoadjuvant chemo followed by surgery when the nodes were negative had a better prognosis. It was better than chemoradiation with negative in the group with negative nodes. When positive nodes, when there were positive nodes in both arms, there were no differences between two treatments. 2016, what happened? In ASCO guidelines and approval by the SGO, affirmed the radical hysterectomy with or without neoadjuvant chemo could be an alternative of treatment, but I believe one of the other important things of this alert that concurrent chemotherapy continue being the standard, but if it only do not delay the radiotherapy treatment. So, with this concept, we can see that not well done chemoradiation had a worse prognosis to performing a standard radiotherapy. Okay, and we assisted to the famous EOTC paper that we could attend yesterday, where compared both arms, neoadjuvant chemo plus surgery versus chemoradiation, and where no difference in overall survival. That was the principal endpoint of the paper. So, neoadjuvant chemo opened up us many doors. For gynecologists, we opened the door for being extremists in surgery, from less to ultra-radical treatments, and opened the door for what to do after neoadjuvant chemo, and what to do in locally advanced 2B and 3B with bulky tumors too. So, why, my question for all of us is, why with so many papers, more than thousands of ones, in favor to neoadjuvant chemo, we are continue discussing about it as another alternative to use in all papers, in all patients. So, I believe this is the answer. We must tailor the treatment to each patient. So we must select the patient to receive one, another, or maybe combined treatment for cure or control the disease. Thank you so much to my mentors and pioneers of the neoadjuvant chemo, Professor Sardi, Professor Di Paola, and of course, thank you to my family and to my fellows, ex-fellows. They are a great group. Thank you, kids. I'm very proud about you. Thank you so much.
Okay. Thank you very much for this kind invitation. Have nothing to disclose. Okay. Well, we gynecologic oncologists are usually seen as well-balanced people, easy people, you know, but this is not always the truth, trust me. We can move in a shades of treatments. When it comes to neoadjuvant chemotherapy, we have that ability to move from one pole to the opposite, from really ultra-conservative surgery to ultra-radical surgery. So, let's start talking about ultra-conservative surgery. For nearly 1 century, all patients were treated the same. You remember that, surely, with a disease with a full radical hysterectomy, whether they have a barely measurable microscopic lesion or 4 centimeters bulky tumors. And this concept changed since Daniel Darchant in 1994 reported his vaginal radical trachelectomy, and it was a watershed because it meant to convince the community of gynecologic oncology that something different could be done, and the opening for fertility sparing procedures. So a woman with a cervical cancer could be treated, and afterwards he also could be a mother. So it is wasn't science fiction movie anymore. It became real. So, what's the rationale for neoadjuvant chemotherapy in fertility-sparing procedures? As we can think a little bit conservative, saying that as survival rates are guaranteed in tumors with less than 2 centimeters, survival rates are really encouraging. Why take it to chance, right? Well, the truth is that cervical cancer is a highly chemo-responsive tumor, and it reduces tumor mass and hypoxic cells, and also it allows sterilization of occult, perimetral lymph node involvement. This means less extensive dissection and the decreased need for adjuvant radiotherapy. So in an early stage, the probability of perimetral involvement is really low, maybe less than 1%. So why overtreat? Why increase morbidity? Do we increase morbidity? This is a question that comes to my mind in the era of ultra-standardized procedures performed at reference centers by gynecologic oncologists, in the era of nerve-sparing technique. Do we really increase morbidity by performing a radical trachelectomy? Obstetrical morbidity is what we are talking about, actually. Well, the point is that Professor Maneo Alandoni went one step further. It was in 2004 at the IGCS meeting that took place in Edinburgh by presenting a pioneering work, the Italian experience about chemotherapy followed by conization for preserving fertility in stage 1B1 cervical cancer. So we all thought, oh my God, what's going on here? And later on, we had the complete publication of these authors by separated 1B1 tumors lesser than 3 centimeters with 3 courses of neoadjuvant chemotherapy. This tip also the so-called MONSA scheme, cisplatin, paclitaxel, ifosfamide, or epirubicin, and conization in some cases with a previous lymph node assessment, in many other cases without lymph node staging, but it boils down to high rates of pathological response with encouraging obstetrical results. But let's get back to radical trachelectomy. We still have a limiting factor. This is a tumor that has to be lesser than 2 centimeters because the association with recurrence is much higher when it goes beyond 2 centimeters, especially those between 2 and 4 centimeters. What to do with these patients? Because chemotherapy followed by conization or upfront radical trachelectomy, it means fertility sparing, but if we go with tumors beyond that, okay, we are talking about a patient that is losing the possibility of preserve her fertility. So then it comes this another pioneering work from Marie Planté, inspired by the Maneo experience, about introduce neoadjuvant chemotherapy followed by radical hysterectomy. A preliminary experience with the TIP chemotherapy regime with laparoscopic node dissection and vaginal radical trachelectomy with nice rates of pathological response. We had also a debate here about gonadotoxicity of ifosfamide, but from then on, many other studies were published, like the one from Robova and many others, showing that it's feasible to add neoadjuvant chemotherapy in order to reduce tumor size and allows a less aggressive procedure that preserves fertility. Here we have the Robova experience that used 3 cycles of chemotherapy, the dense dose chemotherapy every 10 days with the same scheme. and also people who perform neoadjuvant chemotherapy followed by simple trachelectomy. So the range is really wide, and also our experience by abdominal trachelectomy, 5 patients with platinum-based chemotherapy followed by abdominal radical trachelectomy with also good results in terms of radicality and of cervix. So, to answer this question performed by Professor Sardi and Di Paola more than 30 years ago, we had to know that there is a definite trend towards less radical surgery in patients with low-risk cervical cancer. Also, it has nothing to do with neoadjuvant chemotherapy, but it's important to point out that the SHAPE trial maybe would tell us to treat even lesser these patients with a simple hysterectomy. But unfortunately, this initiative wasn't ignited throughout the world for some reason, and no published study has compared outcomes between patients with cervical tumors larger than 2 centimeters who underwent upfront radical trachelectomy versus neoadjuvant chemotherapy followed by radical trachelectomy, simple trachelectomy, conization. So we had this initiative also from Maria Planté in order to organize or delineate guidelines for the treatment of these patients. You know, as you can see here, tumors with a complete response or a partial response will be candidates to perform after neoadjuvant chemotherapy will be candidates to perform a simple trachelectomy or even a conization. So among many things, this also is telling us that maybe it's time to bid farewell to radical trachelectomy, to welcome simple trachelectomy. So let's move forward. The classic debate, okay? What to do in locally advanced cervical cancer, neoadjuvant chemotherapy followed by surgery or concurrent chemoradiation. We love to debate about this at every meeting, at the operating room, at the supermarket queue. We gynecologic oncologists, we always debate about this issue that fortunately has new things to tell us. This ERTC 55994 that was presented by Professor Landoni yesterday or the day before, now show us that it's all relative actually in those 1B bucket tumors. It may be a difference in favor of neoadjuvant chemotherapy, but in 2B, maybe this difference is in favor of concurrent chemotherapy, which seems to be better tolerated and with more adherence to the proposal treatment. But I wonder if these patients enrolled coming from Europe are the same we are treating in countries like Brazil or Argentina. We only, in the public health system, we only have a cobalt energy to perform radiotherapy, and we have malnutrition, homeless people addicted to many substances, whatever. So the adherence to treatment strategies is not the same. We are not treating the same patient here than in Europe. I really like to highlight this topic because it's not minor. And Professor Raspagliese also told us that these high-risk cervical cancer subsets with tumors larger than 2 centimeters, lymphovascular space involvement should undergo concurrent chemoradiation. But we also learned about the influence of the age of the patient at the moment of diagnosis. Young cervical cancer patients may be more responsive than older patients to neoadjuvant chemotherapy. Also, our experience, our clinical alert that I presented yesterday morning. So last word is not said. Maybe in those patients under 35 years old or tumors larger than 6 centimeters, these patients have to be treated twice, even twice, because I always thought if we don't identify patient that will need further treatment, this is adjuvant radiotherapy, we are treating them twice. Okay, yes, but maybe these patients need to be treated twice. I don't know. And the problem of free bulky, we have a real issue here, but the answer is quite simple to this relegated debate. Wait for my next talk, so that we can see how complex this is actually. I mean the talk after the next one. Finally, in the other pole, we can talk about neoadjuvant chemotherapy followed by ultra-radical surgery. Yes, we can do that because we move from one pole to the other out of the thin air sometimes. This usually happens. And we had this Italian experience from Benedetti Pannicci and Landoni that tells us that in 4A stage cervical cancer without lateral involvement, or even in recurrent cancer, this patient could show a benefit by the adding of neoadjuvant chemotherapy followed by an ultra-radical surgery in terms of less morbidity, less bleeding in the surgery. I mean, for the local regional control, it could be an interesting option. Of course, as Professor Soderini said, it has to be tailored. Each patient had to be tailored. Extremely thorough, selected patients in every case, so the treatment is never the same. I think this is the last one. Thank you very much.
Good morning. Thank you for the invitation. It's a great pleasure to be here. My presentation speaks about consolidation therapy after neoadjuvant chemotherapy followed by surgery. In particular, we talk about consolidation therapy, when do them, and what kind of therapy. First of all, let's see what consolidation therapy means. Consolidation therapy was aimed to eradicate residual or occult disease after primary treatment. Consolidation therapy was introduced as adjuvant treatment after chemoradiation. This because cancer patients with cervical cancer and high risk factor have great chance of relapse, local and distant relapse, after standard treatment or other treatment. And in recent trials, the use of adjuvant chemotherapy shown an important improvement in survival. But all started with the study, with the meta-analysis of Colombo, where the use of adjuvant chemotherapy showed large survival benefit. However, these results is based on relatively small trials, and therefore these data are not conclusive. After we have a randomized study, the first randomized study on adjuvant chemotherapy after standard treatment was the study of Dana Gonzalez, and she demonstrated that adjuvant chemotherapy improved survival outcome compared with the standard treatment without adjuvant chemotherapy. After we have so many studies, in the following years, many studies have been published on consolidation treatment after chemotherapy. In particular, in this study, chemotherapy seems to be the best choice for adjuvant treatment. This because chemotherapy resulted in long overall survival and progression-free survival, mostly due to the control of distant relapse. This was replaced by the group of Sardi that was the first to use adjuvant chemotherapy after our subset of patient treated with NACT plus surgery. Consolidation therapy was used for reduce relapse and distant metastasis. However, we have so many studies after chemoradiation, but we have few data after our subset of patients. Now let's try to understand when use consolidation therapy. And obviously, the presence of negative prognostic factor increases the risk of recurrence. Several factors have been found to correlate with clinical outcome of patients treated with NACT plus radical hysterectomy, in particular FIGO stage, tumor sites, lymph node status, and pathological response on surgical specimen. Regarding FIGO stage, this trial of gynecology oncology group shown that adjuvant radiotherapy is suggested also for stage 1 cervical cancer patient with clinical pathological risk factor for recurrence, other than positive node. In fact, we know that the presence of positive lymph node is the most important negative prognostic factor in cancer patient, and in particular in patients with cervical cancer. As we can see in this study, the number of positive lymph nodes are inversely related to survival. In addition, the number of metastatic lymph nodes seems to be directly related to the presence of distant metastasis. However, we must remember that we don't have a single type of positive lymph node. Nowadays, we refer to positive lymph node as macrometastasis, but also micrometastasis and isolated tumor cells. And this is important because the presence of micrometastasis too is an important risk factor for tumor recurrence. And in this study, they shown as this patient should be considered eligible for adjuvant therapy. Now we see another really important prognostic factor specific of our subset of patients, such as the pathological response on surgical specimen after neoadjuvant chemotherapy. As indicated by ESMO guideline, women with risk factor on the pathological specimen should receive adjuvant therapy after hysterectomy. This because some study has shown that pathological response to neoadjuvant chemotherapy seems to be the stronger prognostic factor for the survival of patients treated with neoadjuvant chemotherapy. In particular, this important Italian multicentric study has clarified this aspect. In the study, patients were divided according to pathological response in optimal responders, suboptimal responders with intracervical residual disease, suboptimal responders with extracervical residual disease, and non-responders. In this picture, we can see the data of optimal responders, and we can see as we don't have different in terms of recurrence-free survival and overall survival in patients who underwent chemotherapy, radiotherapy, or no adjuvant therapy. Also, in this subset of patients, adjuvant therapy, consolidation therapy seems to be not necessary. In suboptimal responders with intracervical residual disease, we have a statistical difference in overall survival that was better in patients who receive adjuvant chemotherapy respect to patients that underwent radiotherapy or not therapy. While in suboptimal responders with extracervical residual disease, with positive lymph node or non-positive lymph node, the authors don't find difference in terms of recurrence-free survival and overall survival. However, these data were influenced by the different number of patients enrolled in 3 groups. In fact, we have 11 patients that had no adjuvant treatment, 8 patients that had adjuvant chemotherapy, and the majority of patients had adjuvant chemoradiotherapy. So these data are not conclusive. In fact, subsequently, another study shown different results. In particular, this study shown that adjuvant chemotherapy can improve survival in patients with extracervical residual disease too. Summarized, consolidation therapy is indicated for women with risk factor on surgical specimen such as FIGO stage, tumor dimension, patient with positive lymph node, macrometastasis or micrometastasis, in patient with suboptimal response after neoadjuvant chemotherapy with intracervical residual disease. Is not indicated in a patient with optimal response after neoadjuvant chemotherapy, and to be evaluated in suboptimal response with intracervical residual disease, because in this patient we have patient with lymph node positive and lymph node negative. But in our clinical practice, we do a different type of treatment, because we do adjuvant chemotherapy in all patients after neoadjuvant chemotherapy plus surgery. This because we have to remember that about 20% of patients that we considered as optimal responders had positive lymph node before chemotherapy. Therefore, in our opinion, this patient must be considered as a high-risk patient and may submit to adjuvant chemotherapy. Furthermore, we have the problem of micrometastasis, because often we don't have this diagnosis after surgery, and we have to consider it also this patient. At least we see what kind of therapy is needed. Many studies have shown how chemotherapy is more effective than radiotherapy as a consolidation treatment in terms of disease-free survival and overall survival. Also, in previous mentioned Italian multicentrical study, chemotherapy has the best 5 years survival at multivariate analysis respect to radiotherapy and no adjuvant therapy.
Roberto.
Furthermore, chemotherapy seems to be the best choice also for the minor complications associated with the radiotherapy, such as bladder and bladder injury or bladder dysfunction. But another problem is that we can never relapse. So in our experience, we think that the best choice is chemotherapy, because we prefer using adjuvant chemotherapy rather than radiotherapy, which could be preserved in case of relapse. The best treatment for us was 4 courses of platinum-based chemotherapy for survival and for complication rate. In conclusion, consolidation treatment maybe reduce relapse and distant metastasis. Is indicated for women with risk factor, like tumor stage, but the most important is the positive lymph node. Response to adjuvant chemotherapy on surgical specimen is a very important factor that may help in our therapeutic strategy. Chemotherapy seems to be the best choice, and in our opinion, radiotherapy may be reserved for relapse. Thank you.
So, we had this topic about the problem of stage 2B and 3B working, which is the role of neoadjuvant chemotherapy. So we know that since this clinical NCI clinical alert in 1999, the standard treatment for locally advanced cervical cancer has been pelvic radiation with concurrent cisplatin. However, the proportion of stage 3 patients included in this kind of studies is really low. So it's impossible to reach definite conclusion based only on these results. Indeed, the benefit of chemoradiotherapy seems to vanish in stage 3. 40% of patients have recurrences within 5 years, and survival rates have remained unchanged since 1950. So results cannot be considered satisfactory. And we have to be aware which patients are we dealing with. patients with hydronephrosis, with bilateral parametrial involvement, with a huge bulky tumor, a central tumor, also bulky lymph node involvement. So development of new therapeutic strategies, I think, is wholly justified. And we also know one thing, that neoadjuvant chemotherapy as a screening method to select chemo-sensitive patients and avoid them further meaningless cycles. So, as I said before, not many trials have included 3B stage patients in their analysis. Maybe a pioneering work was this performed by Sardi from the University of Buenos Aires, randomizing
Assistant, please.
Yes, here we are. With this randomized trial with neoadjuvant chemotherapy in 3B stage. And the one performed by Sardi, it was in 1996 with this BBP scheme, this so-called quick BBP scheme, vincristine, cisplatin, and bleomycin, and randomizing 3 arms in which the control group, the radiotherapy treatment, show survival rates as usual. This is between 30 to 40%. In this case, 37% survival rate, similar to those reported by many other authors with conventional treatments. And once again, suboptimal response to neoadjuvant chemotherapy seems to be a prognosis factor of poorer outcomes. So we have to deal with these patients as well. What to offer? What can we offer them? But this is actually true. We are much more concerned these days about lymph node mapping and assessment and the different approaches for surgical treatment of early stage. And what about developing of new strategies for these patients with the awful prognosis? And the problem of adherence to treatment as well. 1% of a loss of local control rate ranging from 1% per up to 2% per additional day of treatment. In our experience, there may be 2 scenarios in which the therapeutic efficacy limit of concurrent chemoradiation is exceeded. Tumor size beyond 6 centimeters, and of course, those patients with para-aortic lymph nodes. It was published, was debated yesterday as well. And what about our patients? We can see here, 31% of our patients are admitted in a 2B stage, and 30% in a 3B stage, with overall survival rates about 16% for those with a tumor size larger than 8 centimeters. So these patients don't have a therapeutic strategy nowadays, at least. So it's our challenge to find out a new therapeutic strategy for these central bulky tumors. Some papers were published. Here we had a nice experience from the Sapienza University from Rome, neoadjuvant chemotherapy followed by radical hysterectomy with a high rate of recurrence, with rates of survival in concordance with the previous studies. But this is important to point out that this strategy also allows some rescue treatment options by not offering radiotherapy as an upfront strategy. the British experience using a neoadjuvant chemotherapy followed by concurrent chemotherapy, something that was later replicated in some cases. And we also have here a Brazilian interesting work. In this case, the study concludes that cisplatin plus gemcitabine to add this scheme to previous to the standard concurrent chemoradiation is not superior, but also maybe inferior to concurrent chemoradiation alone. This is new from a few months ago, so we have to pay attention to this as well. Professor Soderini already told us about the better scheme of neoadjuvant chemotherapy is the one that is available, actually, especially in low resources settings. So we have to keep on trying, identifying new strategies. I think that the last word is not told yet. Maybe collaborative trials in countries like this, like Argentina, Brazil, South America, in which cervical cancer with bulky tumors at early ages is a real problem. So I hope we can